Please feel free to write that in the chat box, and we will be addressing all the questions at the end of the session. And if there is anything else that you would like to discuss, just raise your hand, and then we can discuss that. This is a very friendly kind of a session, because I'm also an IMG just like you guys. So just feel free to share whatever you want. And I think we can just start the session. You guys can see my screen. Okay, so this is the logo of my channel, and I've designed it with heart. This is Medicine by Heart, and this is in view of all the IMGs, including me. It represents our struggle and our love for medicine. So today's session's objective would be, just 1 second, let me move my screen forward. Yeah. So today's objective would be, I will be having some more sessions also, some more free sessions also. But today's objective would be that I would be sharing an overview of the NAC, that what NAC looks like. And apart from that, I will be solving a scenario of chest pain with you guys, like the first part of that. And in the third part would include the outline of the course that I would offer in order to prepare for the NAC. So this would be our agenda for today. And in the end, I can answer all the questions that you guys have. So, okay. So a little bit about me. I am an IMG, just like you guys. And I started my journey for exams of Medical Council of Canada in 2021. Till then, I have been lucky enough to go through the experience of the exam. There have been some bitter experiences. There have been good experiences. But from last 1 year, I have been working as a volunteer physician assistant with one of the doctors here in Canada in a family medicine clinic. Apart from that, 2 years back, I was lucky enough to represent the problems which are faced by IMGs to the Health Minister of Alberta, Mr. Jason Coping. At that time, I was a part of a delegation who visited him, and I was lucky enough to represent the problems of IMGs. And for that reason, it gave me a thought that I should, interact with a broader set of audience, and all the problems that we as IMGs are facing, we should make each other's lives easy. We are all in this journey. So if one is ahead of the others, he should be an anchor for the people who are coming up after next. So apart from that, I have some coaching experience from back home. I have been teaching some undergraduate students. I do some volunteer work as well. I'm a part of, I was a part as a volunteer of one of the cancer institutes here in Calgary. I have been working with some of the international, medical doctor teams as a volunteer. So this is a brief description about me. Now, this slide is that what is NAC? So NAC is basically National Assessment Collaboration. This is the short form of this exam. And what does this mean? This means that this is an exam on which the entire Canada is appearing on the same day, and they are having the same set of questions on that particular day. That means that you really have to put an effort to stand out among those people, because it is the same set of questions. The person who's going before you will be asking the same set of questions like you, will be tackling the same case like you, and the person who's going after you will also be doing the same. So what you should be doing to represent yourself differently, that is something that my focus is, even in my course and in today's discussion as well. So for me, NAC is not just a normal exam. It is also your performance on that particular day. Those few minutes inside the room, they define your marks. They define that where you will stand as compared to the person who went before you and the person who's coming after. And thousands of those other students who are giving the same exam on the same day in different areas of Canada. So that's why I feel that this exam, for this exam, you really need to be crisp in your approach, and you really need to be very sharp in catching the questions, in knowing the clues, in getting to the point that if the SP, the standard patient, is saying something, what does that mean? Because we all know that all the patients who are in the NAC, they are not like normal patients, they are actors, so they have a script. So whatever information they are giving, it is for a reason. So how to, gain maximum out of that information in those 8 minutes, that is your agenda for the NAC. So it is a bit different from QE1. QE1 is very theoretical. It is different, but NAC is all about your communication skills. It is about your soft skills. It is about your body language. It is about your aptitude with the patient. So it tests you on a lot of other things, which we as IMGs really struggle in, because back home in our countries, we are not taught medical ethics and patient communication and what to say and what not to say and where to stop. So this NAC is altogether it's kind of a personality training for us. It's not just a medical exam, it's a personality training. And trust me that after giving the NAC exam, when I saw my result, I was surprised to see that they had addressed all those areas that we just neglect. That how did I communicate with the patient? How was I able to wrap up the case? And those were the things that helped me to get some good marks. And those were the things that made me confident that, yes, maybe, I can help the other IMGs to achieve this. Now, as I said, that it's a half-day exam, okay, 3 to 4 hours you are in that room. And now the pattern is that you have 12 stations, 2 of which are the pilot stations. They are just to assess that what kind of difficulty the IMGs can go through. The rest of the stations are 11 minutes long. So what do that 11-minute long station means? It means that you have 2 minutes outside the room, you have 4 minutes for any of the tasks like history, or 4 minutes for examination, or maybe you will have a combination of 8 minutes for a counseling station. You might have a whole examination scenario. So it depends that what you have, but you have 8 minutes in total with the patient. And then 3 minutes are there for the post encounter. That means on those 3 minutes, the examiner will ask you 3 questions or 2 questions, depending upon whatever is there with them. And you have to be very crisp in your approach, because if you waste a lot of time in answering one question, you will miss your second question, because the moment the buzzer rings, you have to leave the room. You cannot stay there for your next question. So that is it's your exercise against time. It's your race against time. It's a test of your knowledge against time. That's why I feel that NAC is like an overall personality training. It's a training that how quick and how like in a real life. I won't say even in the real life, because even in the real life you have more time. But in NAC you don't have. You only have those 8 minutes inside the room. Okay. So in NAC, you can have different questions outside the door. Okay. I feel that there are 4 types of patterns which are outside the room. It can be history and physical exam. It can be history and counseling station. It can be history only, and it can be examination only. Examination only is very rare. Usually it is in the section of neuro, when you have to do all the cranial nerves, and it is really very rarely heard of that it comes. But this is one of the things that they will give. If it's a very long examination, that will be your task, which is very unlikely. But most of the stations, they are history and counseling, or history and physical. And I'm more focused on the counseling part, because that is the place where IMGs can score very good marks, because everybody's going to do the same examination. You cannot change the examination of the patient. In history, yeah, the history taking skills, you can work on them, but more or less everybody will be asking the same questions. The part which will make you different from other IMGs and which will help you score more marks, that will be the counseling station. In my exam, I had 4 counseling stations. I know someone who recently had an exam and they had 5 counseling stations. So counseling station is a double-edged sword. If you are good at counseling, you will ace your NAC. you will get this, it will give you maximum marks. Even if you mess up some of the examination, even if you mess up some of the differential diagnosis, the counseling is something that is really going to work for you. So my focus in, especially in my course as well, my focus will be on counseling stations. I will be working very hard with my students to help them practice their counseling skills, what to say, what not to say, at what time you need to say that, okay, I don't know this. Maybe, you should know when to stop as well as an IMG. So this is something that I would like to focus on in my careers. Now, time division, as I already mentioned, you get 2 minutes outside the door. I have written 1.5 minute here. Why? Because you spend almost 30 minutes from running from one door to the other. So apparently, 30 seconds, sorry, you spend just 30 seconds while running from one door to the other. So apparently you get 1.5 minutes outside the door. In those 1.5 minutes, you have to read the scenario, you have to make a list of your differential diagnosis, and you have to write your template. So it's a lot to do in 1.5 minutes, and that is not something that you can just cook outside the door over there. You have to have those reflexes in your NAC course. When you will study your NAC course, you have to develop those reflexes in order to train your mind that the moment you read the scenario, the moment you read, sometimes the labs are also given outside. So the moment you leave there, you read the entire scenario and the labs and everything, even if you have 5 seconds left, even if you don't get time to write anything on your booklet, you should be able to go inside and talk to the patient and continue. There will be stations when your template will not just work. You will go inside and you will say, oh, it's a different story. I thought something else outside. So that's why this 1.5 minute, which is outside the room, is very important to calm yourself down and to know that what you are going to do next. Then you have, usually I divide the time in 4 minutes, 4 minutes for history, 4 minutes for examination or counseling. Both things can go hand in hand as well. Then you get 3 minutes of post-encounter. Those 3 minutes belong to you and the examiner. The SP is quiet in that time. The moment the buzzer rings, the patient just stops talking. Even if you have asked a question, they will not answer it. Then the examiner jumps in. The examiner asks you your 3 questions. If you stuck on the first question and your time is over, you will miss your 2 questions. So you have to be very crisp on those 3 minutes. 3 questions, you should really know your game well, that, okay, what I'm going to say, if I get stuck, what I'm going to do. So all these things, these are to be practiced during the NAC course, because if your brain is not trained on those 3 minutes within the room, you will not have the time. You will not have the time to rethink or recook or think about anything. And then you will mess up your next station as well, because you will be stressed that, oh, I messed up my last station. I missed a question. So you are your boss at that time, that you have to drive the examiner and the SP and everything with your time and your speed. This is something which is very important and which needs to be learned. It's not just about studying Toronto notes or studying first aid. It is about training of your mind, physical and mental training, both. So now, just to have a flavor of NAC, let's practice a scenario together. Is there anyone who would like to volunteer? You don't have to turn your camera on if you don't want, but just, if you want to volunteer to practice a scenario, that would be great. I'm able to help you. I'll be able to help you here. So anyone, if you want to volunteer, please raise your hand. Anyone? Anyone brave enough? Okay, so we have a volunteer. That's very nice. One more thing about NAC is very important, that you have to come out of your comfort zone. You have to do mistakes. That is how you're going to learn. Okay, so I'm going to unmute a iPhone. I'm sorry,
Hello,
okay.
I'm
Hello.
Aya.
Yeah, okay, Aya. Good evening. How are you?
Good evening. I'm good. How are you?
Good, thank you. Thank you very much for volunteering. And just don't be confused about anything. Even if you make mistakes, we are all here to learn, okay?
Okay.
And I'm here to help you. So let's practice a scenario together and see that how we can dissect this case in a real, NAC scenario. So the scenario is about chest pain. It's a very favorite topic of examiners and a very common one as well. So we have a 40-year-old male. He's a known smoker and comes to ED with chest pain, and you have to address his concerns. So I can help you with the startup. Aya, have you ever practiced any questions before this? Or is it?
No, this is my first time
Okay.
actually practicing. Yeah.
Okay, no worries. So let's go to the next slide. So now, this is the time for your thought process. The one that I mentioned, that you have 1.5 minutes outside the room, and all the other participants, they are more than welcome to write their answers in the chat box. So can you make a list of differential diagnoses considering the scenario that I just said? That a patient,
Okay.
40-year-old male smoker with chest pain. What would be your differential diagnosis?
So the first one will be myocardial infarction.
Okay.
The second one, aortic dissection.
Okay.
The third one, pulmonary embolism.
Okay, nice. Other people can just write it in their chat box, in the chat boxes if they want, or they can just write on a paper just for their own practice. Yeah. Anything else that you would like to add?
Pneumonia.
Okay, nice. Yeah. Anything else?
Oh, no, that's it.
That's it.
all.
Okay. That's fair enough. That's a good differential diagnosis list. Okay, and the next part is writing your basic template. We will discuss that how we write the basic template of a history by moving forward. Now, I have a question that when you were telling me all these differential diagnoses, did you have any plan in mind that how do you make your list of differential diagnoses? In any scenario, just not here, like any time you have to make a list of differentials, do you follow any pattern?
Maybe if it's acute or chronic.
Okay, good.
Yeah. And if the pain is radiate somewhere else.
That you will know with the history, right?
Oh, okay.
Yeah, but with the pain, what is the quality of the pain and how the pain looks like? But just reading the scenario, just reading the question stem, what do you think of the list of differential diagnosis? Like, how did you make the list? Was it a random list, that thing that just came to your mind out of reflexes?
No, it like depends, like anything will cause chest pain.
Okay, good. Okay, so now this is how I make differential diagnosis, okay? From NAC point of view, especially, whenever you are making a list of your differential diagnosis, remember the mnemonic SPIT. What is SPIT? SPIT means that your list should include some of the serious conditions, one of the probable condition that would be your most likely diagnosis, one, anything interesting, rare, it should be in your list, something with a twist. And the last thing is that whatever condition you're writing, is it testable, treatable, there is a possible treatment available for that diagnosis. So whenever you're making a list of differential diagnosis, especially from NAC point of view, you have to be sure that your list is extensive, because when you're going inside, you don't know what's coming up next. Okay. So you made an amazing list: MI, aortic dissection, pulmonary embolism, pneumonia. That is very good. Now, one more tip for NAC is that whenever you are making a list of your differential diagnosis in NAC, you should see that what systems are you covering. At least you should focus on 2 to 3 systems. Now, this chest pain focuses on your cardiovascular system. What is the next system adjacent to the cardiovascular system? Next 2 important systems are your respiratory system and your GIT tract. Okay, so let's think of any differential diagnosis from the respiratory system and from the GIT tract. So we have pneumonia from the respiratory, okay, but we have nothing from the GIT. And what if you just go inside the room and you find out that, oh, the patient has GERD? See? So that's why we need to have an extensive list. If you can add one more system to the list, that is a jackpot. For example, let's suppose that you add derma to the system and you say, okay, it's herpes. Maybe the patient has a rash and that is a chest pain, or maybe it's just, costochondritis. So you are involving your MSK. You can think of simple pleuritic pain, So like your your differentials should be very wide and they should cover all aspects, because NAC is something that when you go inside the room, it turns out to be something else. I'm telling you from my personal experience, when I went on one of the stations, the scenario outside was just prescription refill. When I went inside, uh, the prescription refill was from a medicine in gyne-ops, and surprisingly, the station was dealing with depression. It was a psychiatric station that I found in the end. So, you know, in NAC, this happens a lot, that whatever scenario you read outside, things can change dramatically inside the room. So you need to have an extensive list. You made a wonderful list, and let's go to the next slide. Now, considering the scenario, okay, so this was the probable list of differentials that I had. Pulmonary embolism, angina, GERD, pneumothorax, herpes, cocaine, very common and very favorite of test takers as well. Aortic dissection, I'm sorry for the call, okay. Aortic dissection, and then it can be panic attack. Okay, you should have a psychiatric differential as well. So this is one of the extensive lists of differential diagnosis. And you always need to have a serious diagnosis in your list of differential diagnosis. And why is that? Because that will tell the examiners that you are a safe doctor. You are always ruling out your red flags. You're always ruling out the life-threatening conditions. So because they have to make sure that you are not going to kill the patient. Okay. So your list, whenever you make the list for your NAC OSCE, you should know that it has serious conditions, it has non-serious conditions, it has common conditions. So this is just a small approach, you know, how to make a list of differential diagnosis. Okay, so this is the basic history taking layout. Okay, this is how you take basic history. You introduce yourself, then you ask for the chief complaint of the patient, you ask for medical history, family history, social history, and then you wrap up. This is a basic history layout. Things can change when it's a child, when it's a woman, it's a pregnant woman. So things can go up and down a little bit. We can add and subtract a few points here and there, but this is the basic layout, okay? Okay. So how do you introduce yourself? You knock the door, you enter, you sanitize your hands, you introduce yourself that I am doctor. For example, if I go inside the room, I just say, hello, I'm Dr. Umar. I'm your physician for today. And can I confirm your name and age? And then the patient tells you that, okay, this is my name, this is my age. And then you ask the patient that, okay, how would you like to be addressed? Because, you know, they might tell you that I would like to be addressed as this is my name, but I want a shorter version or whatever. And the examiners and SPs are very sensitive about the name. So if you feel that you will forget the name or you will forget he, she, the pronouns or anything, just write it on the corner of your notebook quickly while talking to the patient. Keep your eye contact maintained, and your body language with the patient should be very friendly. You should not be focused on your notes and your books. No. If you do that, you will lose marks. So when you're talking to the patient says, okay, my name is maybe Jessica, but you can call me Jess. So just write on the right of corner of your notebook or anywhere, Jess, okay, quickly, and how he or she would like to be addressed. That's it. Then this is how your brief introduction is there, okay? Then you start with an open-ended question, okay? That what brings you in today, or how can I help you today? Even if you have read outside on the door that the patient has chest pain or whatever, start with an open-ended question and listen to them. They will tell you their story. But if you just draw the conclusion that, okay, I understand you are here with chest pain, they will just talk about that. So give them a chance to speak and start with an open-ended question that, okay, how can I help you today? What brings you in today? Okay. So then the first part of the history is the chief complaint. Okay, chief complaint, this is a very basic template. We all know onset, position, quality, radiation, severity, timing, trigger, impact. So Aya, if you can volunteer once again, would you like to ask some questions based on this template? If you're okay with that?
Okay, so could you tell me, please, when it start exactly?
Yeah, doctor, the pain is there for past 6 months now.
Okay. I can see. So it radiates somewhere else in your body.
Yeah, it sometimes radiates to my neck, sometimes it's all over my chest.
Okay. In a scale 1 to 10, if it's 10, the most severe pain, what number is it gonna be?
Maybe six, seven, sometimes it's four as well. Yeah.
Okay. And the pain is it gradually or a sudden?
Um, Sometimes it's gradual, doctor. Sometimes it just starts all of a sudden. And it really bothers me. Sometimes it wakes me up as well at night.
Okay, so it's for 6 months and woke you up at night.
Yeah.
Um, any relieving position or that can settle the pain down?
Yeah, I think sometimes if I just keep my head and raised a little bit, then I can sleep better and it helps me.
Okay, now I would like to ask for another symptom.
Mm-hmm.
Have you had any fever?
No,
How about night sweats?
no.
Uh, how's your diet recently? Have you been eating?
Yeah,
Mhm.
actually, I love to eat. I'm a big eater. So, recently I've started like from past like 8 months, I'm trying, some intermittent fasting because somebody told me that it's really good for me. And I had gained a lot of weight because of my eating habits. So now I don't eat throughout the day. I just eat one big meal in the afternoon, and that's it.
Okay. Uh, can I ask you more question about your history, medical history? Do you have diabetes,
No, I don't.
hypertension?
No.
Okay. Um, yeah, I can.
Yeah. No, thank you
Yeah.
very much, Aya. That was really good. And you have covered this first part, which is the chief complaint very nicely. Now, a
Mm,
few things that I would like to mention here and there from NAC OSCE's point of view. You asked me that, okay, when did the pain start? I told you that it started 6 months back. Okay.
mm,
But if you go back to the scenario, let me go back a couple of slides back. Yeah. So it says that the patient presented to emergency department and address his concerns. Okay. So when you look at this question, what do you think? What kind of question it is when we discussed like 4 questions of NAC OSCE that some are with history and some are with counseling and some are the physical exam. So what do you think the station is asking you to do?
just taking history.
Just taking history and
Yeah, this is address his concern. Yeah, yeah,
yeah, so you have to
mm,
counsel the patient. So
yeah.
these
We
are two
cancel.
tasks which are, they will not write, sometimes they might write that counsel the patient, but usually they write addresses concerns or talk to the patient, uh, things like that. So this station is basically a history and a counseling station, okay? Now, it says that the patient is in ED, emergency department, okay? And the
Mhm.
patient tells you, when I go forward, here, okay. Now, the patient tells you the patient is having pain for last 6 months, okay? So now, because Nakoski wants us to be a detector as well. So like a detective, you should ask, okay, so you had this pain for 6 months. What brings you in today? Like what happened differently today that, you are the patient is coming to emergency, the patient is not coming to your,
Okay, yeah.
yeah, okay.
Mm.
So then when you ask this question to the patient, then the patient will open up and the patient might tell you that, recently I had a friend and, the friend had a heart attack and the friend died. So I'm really concerned about it. And that's why I'm here. Now that just changes your entire station because now you have to address his concern because the patient is scared that his friend died and the patient is thinking that, I might have an MI. So this changes your entire perspective of the station. This is how NAC OSCE looks like. And I have chosen a very simple scenario of chest pain just to give you a flavor or an idea that how things work in NAC OSCE and non-NAC OSCE stations. So now when the patient tells you that, yeah, today I came to emergency department because my friend died of heart attack and I have this pain all the time for 6 months. So now you have to address his GERD, and you have to address his concerns as well. So now this station becomes your counseling station. So this is then the basic template. You will ask about the timing, onset, setting question. It's up to you. If you want to ask the patient that why did he came today when the pain was there for 6 months, or you want to ask about ruling out all the red flags. Okay, in every part of history of presenting illness, you should always rule out red flags, never miss them, and the risk factors. In this case, the red flags were fever, night sweats, weight changes, appetite, because you're going to rule out some of the conditions which can be life-threatening or which can be a public hazard. For example, what if the patient has, any carcinoma or tuberculosis or something like that, and it's a tuberculous pneumonia that the patient is coming with. So then your task as a doctor becomes even further longer. You have to inform the public health. You have to vaccinate the people who have been exposed, and all those stories that come in the later section of the NAC OSCE scenario. And the risk factors, it's very important. He's a 40-year-old male. He is a smoker. Okay, and as we were discussing your differential diagnosis, aortic dissection can be very much there. MI can be there very much. So always rule out, even if you don't have time inside the room, always rule out risk factors and your red flags. So this will be your, a message to take with you, to your take-home message, that never miss these 2 points. And whatever the SP is saying, because it's a scripted thing, if they're giving that information to you, that means that it is written there for a reason. It is not just written there because they just want to talk to you. They're giving you that information because there's a background story. Okay, so you should see that where the patient is coming, emergency department, okay, and the pain is 6 months. So the pain is not acute, but what happened that he acutely had to come here. Okay, let's go to the next slide. Now, when you ask all the questions, like onset, that when the pain happened, where does it radiate, what makes it worse, what makes it better, and all those questions, now you're able to narrow down your differential diagnosis. So you have ruled out a lot of things, like you ruled out MI, you ruled out aortic dissection, you ruled out pneumonia. The patient said, I don't have fever, I don't have cough, I have not traveled recently anywhere. You have ruled out everything. Now you ask the patient about the appetite, and the patient tells you that, oh, I ate a big meal, and I'm doing intermittent fasting. Now this thing gives you two informations. Number one, the patient is obese, because the patient said, oh, I had gained a lot of weight, So number one, the patient is obese. And number two, the patient is doing intermittent fasting. That means that he's having one big meal in a day. So that is pushing him more towards GERD. Okay. At the same time, the patient told you that, I feel better when I'm sleeping with my head raised. So what information so the things are pointing a bit towards GERD when you have ruled out MI. So now, once you have asked the questions related to cardiovascular system, you have to rule out at least 2 other systems. So you will ask there are a cluster of symptoms for each system of the body. Cardiology has a separate set of questions, a cluster of symptoms that you do have to ask. If the patient says, I have chest pain, you will always ask about pain after eating to rule out mesenteric ischemia, pain after walking to rule out intermittent claudication, because the patient is giving you a history of ischemia. So you have to rule out ischemia in other parts of the body. If the patient gives you a history of bleeding, you have to rule out bleeding in other parts of the body. So this is how NAC OSCE works. And I will be discussing all these things in detail in my course. Anyways, so now since we are focused on the cardiovascular system, so you ask the patient the questions related to the chest pain. They are from the CVS. Now you will ask questions from 2 other systems. What are the 2 next door symptoms to cardiovascular system? Your respiratory system, number 1, and number 2 is your GI. So from the respiratory, you ask the patient, do you have cough? Do you have night sweats? Does the pain get worse on walking? That's from the CVS system. From GI, you will ask, do you feel any metallic taste in the mouth? Okay. You can ask, okay, so you're saying that you have recently gained weight. How much weight did you gain? Okay, so do you snore while sleeping? So all these things, they will add on to your differential diagnosis, and they will tell the examiner that this person knows how to narrow down, because you are the one who is taking the examiner towards your differential diagnosis. So you have to tell your questions in a way so that you can narrow down towards your differential diagnosis, whatever is in your mind. NAC OSCE is, they're not looking for a clear cut or one diagnosis, one single diagnosis. They know that even in the real life, you cannot be very sure about everything. What they want from you is that, do you know how to narrow down your list of differential diagnoses? Because at the end of the station, they will ask you, okay, give me 3 top differentials, or give me 2 of your top differentials, you know? So this is very important, that you should know the right questions in that time. Okay. So, if Anis can kindly unmute themselves. Anis can kindly unmute. Yeah, thank you. Okay. So this is how you answer questions. Now, there are cluster of symptoms from each and every system, the relevant questions to ask from each system, and how those questions are asked, how those things are, that is all about NAC OSCE. That is what NAC OSCE is all about. That how you ask your questions, how you reach your diagnosis. And that is something that will be different from others. Physical examination, everybody knows how to do that. Everybody is an expert on that. Everybody knows that what they are looking for. So the 2 things that will give you an edge over the others would be your history taking skills, number 1, and number 2, your counseling skills. Counseling skills are the favorite part of the examiners, because they know that we as IMGs, we really struggle in that. We really struggle in talking to our patients. We really struggle in, developing that doctor-patient relationship. So this was the portion of history of presenting illness that we completed in today's class. Now, rest of the components of history, which are the past medical, family history, social history, I will be discussing them in the next session, and the counseling as well. I will be doing the counseling for GERD in the next section, because GERD is a very common station, and it is one station on which I think entire Canada will just score 80%, because it is such an easy topic to deal with. So what you should do differently, that if GERD comes, how you should make sure that you can score 81% instead of just the 80% that the entire Canada is achieving. So for that, it is very, very important that you should know your words, and you should know how to concise those words in those 4 minutes effectively. So this was NAC at a glance that we just discussed, and how to prepare for that. Now, what makes my course different? The thing is that, there's so many courses out there, and everybody has a free choice to take whatever course they want. But the thing that will be different in my course, that I feel, because I myself have taken a lot of courses when I was studying for NAC. So there were things that I felt that were lacking in some of the courses, and I have tried to incorporate that into my course. And what is that? I will be giving a written feedback after completion of every unit. Like, for example, when we complete the GI system, everybody will present in the class, and that session would be recorded, not video recorded. It will be an audio recorded session, and then I will send you the files in written form, so that when you practice those scenarios once again with your study partner or in your free time, you should know that what mistakes did you make and what you should not do, and you will have your own script written rather than just writing it by yourself. I have my notebooks full of, my own scripts that I used to write after taking the classes, because I never wanted to forget that what discussion happened. So number one thing is that I will be sending after completion of one unit. For example, when we will complete GI or respiratory or cardiovascular system, I will be sending you a written script. Of all the cases that we will do in those sections, you will have the script of them. The other thing is that I will be taking, I will not be taking more than 12 to 15 students in one batch. And the reason is that I want all the students to participate. I took a few courses in which I was not given the chance to participate. I was able to take the class, but to present a case in the class, because the time was over, the participants were too much. And I think that NAC OSCE is all about participation. The more you talk in front of your fellow colleagues, the more crisp you are in what you're saying. So these two things are different in my course as compared to other courses out there. The third thing is that I feel that I'm an IMG and I'm just like you, and I know the struggles that all of us have when it comes to communication and it comes to doctor-patient relationship. So maybe, I can fine-tune a few things here and there. And plus with, after working as a physician assistant for the past 1 year, I have learned a lot of things from the actual, patient interaction, that how it is done and how what is being expected by the examiners, because the examiners are the normal professors and doctors. So now I know that what are they looking at, your body language, how so I feel that now I can guide my fellow IMGs in that aspect. The bootcamp details are as follows. I would be starting my classes from January 6th, and they will go all the way till February 26th. There will be 2 days in a week. We might increase the number of days depending upon how we are covering the course. Timings would be 9:30 a.m., that is in the morning, to 12:30 p.m. We might go half an hour, ahead of time as well. We can extend the class up to 1 o'clock as well. It depends upon, how we are progressing and if everybody's on the same page in the class. So, but it's 9:30 to 12:30. Fee for the entire course is 400 Canadian dollars for 2 months per student. And my plan is that we will be covering at least 140 to 160 high yield cases that will be focused on not just the physical exam, but counseling. I will give you all the materials. I will provide you with the slides that I will teach in the course. You will have access to everything. And as I mentioned earlier, that number of students in each batch, my target is not more than 12, because I want everyone to participate. Even if anyone gets to participate twice in a class, it's a jackpot. So not more than 12 students. And in 2 months, like by end of February, we'll be done with the course. And all my students, they are like, if they want to observe any of the classes which will be going on, they will be more than welcome whenever. Not just like in general. If you're my student once, then whenever I'm doing a class, if you want to observe another class which you are not a part of, you will be more than welcome to join that NAC class. These are the units that I would be covering in my course. As you can see, there are 16 classes mentioned here. So we'll be covering all the high yield units: GI, resp, cardio, uro, nephro, neuro, MSK, endo, peds, obs, gynae, and psychiatry. Some of the classes that the material is not that much to prepare from, so I have just kept one class for that. But as I mentioned, that we can always, add more classes. These are the topics, almost 15 topics that I will be covering from cardio. These are the topics from the respiratory system. These are the GI topics. You can see the GI is one of the biggest ones and one of the favorite ones as well of the test takers. So it has a lot of topics that we will be covering. Almost 17, 18 topics from the GI. From nephro-uro, there are almost 7, 8 high-yield topics, and usually questions just to revolve around all those 7, 8 cases. So we will be discussing that. From MSK, yeah, MSK is also one of the favorite. There is usually one question or one station that involves MSK. So we'll be doing 11 topics from there. Neuro, once again, very favorite of test takers. And neuro they are more interested in counseling, neuro counseling, rather than examination. There are a lot of counseling, stations when it comes to neuro. For example, counseling of epilepsy, counseling of migraine, counseling of a drug seeker, counseling of depression, and arm weakness. These are all domestic violence, a very, very favorite topic of exam takers. So endorheumatology, again, there are almost 7, 8 topics, and we will be covering them. And then there are some miscellaneous topics. This list is not the final list. I might be adding a couple of more topics. For example, smoking counseling is there, obesity is there, hyperkalemia is there. So some of the important things that, you know, test takers like, I might be adding a couple of more topics into this miscellaneous list. But these are the 10 topics. So altogether, it will be almost 160 cases. That is my target. We can go up to 200 as well, depending upon at what speed the class is going. So in Obs Gynae as well, you can see that we have almost 12 topics. In Psych, we have almost 9 topics that we need to work on. Peds, again, it's one of the favorite ones of exam takers, and I have, shortlisted almost 16 topics from Peds that I will be covering with my students. So that was pretty much from my side. If there is anyone who would like to ask any questions, if there are any confusions, please go ahead and ask me. I'll be more than happy to answer. Yes, please, Hajar, go ahead.
Yeah, can you just put the slide for the cardiovascular topics again?
Sure. You want to take a
That's very cool.
screenshot?
Yeah, I want to see the topics.
Yeah, sure.
Thank you.
Okay, so these are 15 topics from cardio that
Yeah,
I'm
thank you.
focused on. Okay.
Sure, questions.
Okay, so there are some questions in the chat. I will just see that now. No, there's nothing in the chat, I think. Yeah. Mm.
I have a questions, doctor.
Yes, please. Dr. Shahida, please go ahead.
Yeah, so you didn't mention anything about like emergency medicine. Is it on the miscellaneous, that part?
Yeah, no, what happens is that all these topics that we have here, so in NAC, it is a bit different. What is here that, for example, this angina, your panic attack, the acute pericarditis, this AFib, all this can come in emergency topics. So in NAC, they ask you that they can give you a scenario that this patient a chest pain patient can present to you in the ED. A chest pain patient can also come in the your normal clinic. So all the topics, they are mixed. Like emergency medicine is not that I would say it is very separate. For example, if I go ahead to just give me a minute. Asthma. So this is asthma, COPD, exacerbation. These are all emergency topics, okay? If we go to GI, you can see DKA is here, acute pancreatitis is there, mesenteric artery occlusion is there, perforated peptic ulcer is there. These are all the emergency topics, which are hidden in the main topics. If you go to this nephro-uro, you can have UTI presenting there. Then in MSK, you can have this multiple sclerosis presenting, or this, what is cardiac vena syndrome. In neuro also, you can have a patient with migraine and all that, So this is all, yeah. So all the emergency topics, they are mixed. They are in these topics. So when we will be covering, for example, one unit of neuro, it will cover all the topics, not just emergency and the other one as well. Yeah. Yes, sure, Nandini, just give me a minute. I just saw that you just joined in. I will go back from the beginning and I'll show you all the slides in the end. Yes, Hera, please go ahead. You have a question?
Hi, Sana.
Hello.
Yeah, thank you for the class. It was really good, very amazing, and
Thank you.
all the best for the future. So, yeah, so my quick question, like, so most of us probably would have already done QE1, and for that, we pretty much did Toronto notes for theory. I'm
Yeah.
a little confused, like, what else we should do when it comes to NAC if you want to refresh our theory? Is Toronto notes enough, just going through that? Or I've been reading a lot about Edmonton Manual, which I've never done before. So do you want me to like stick to Toronto notes for theory, and definitely for, like even to pick the differential diagnosis, we should be excellent in theory, right? Without that, like we don't know what the patient is talking about, right? So what theory book you want to recommend that is not, like we're not wasting our time and which is actually precise for NAC OSCE? Thank you.
Okay, so Ahira, thank you for this question. The thing is that NAC is a bit different. It's not like that reading Toronto notes will give you this this edge. In NAC, what happens in NAC is that they are actually looking at your list of differentials. So for those differentials, for example, I'll just let you know that in this slide we have, let me go back a couple of slides. Okay, so for example, in neuro, you have epilepsy follow-up, okay, that the patient is coming to you for epilepsy follow-up or migraine. You should just know the name of the medicines that you would prescribe, okay, some investigations, and what kind of investigations you're going to do, or maybe they will give you an ECG to read in post-encounter, that the patient is there with chest pain and everything, and you're done with history and everything, and then they give you an ECG and they tell you, okay, can you interpret this ECG for me? Or they give you an X-ray. So NAC does not need your theoretical knowledge the way it is for QE1. Even if you know the topic inside out, you can answer. It will just help you for the post-encounter questions, which are 3 questions for 3 minutes. The main focus of the NAC is on the question asking skills, that how quickly in 4 minutes you can ask. And for that, I think Master the NAC is a good book. Edmonton Manual, I will not recommend, because Edmonton Manual mostly has this pattern which is called SOAP. SOAP is that subjective, objective, your assessment and plan. So that in NAC OSCE, you have to go a little bit in more detail. For example, that your history taking skills, you have to ask history representing illness and past history and family history, and then social history. If it's a child, it's Bindi that you have to ask about birth history, immunization history, and development. And so, it changes. And so I will not recommend that you read Toronto notes very thoroughly. I would just say that whatever your differentials are, for example, if you are studying migraine or a cluster headache, you should know what is the treatment, what investigations will you do in that scenario. That's it. You don't need any nitty-gritty details. And for the list of differentials, whatever system you will study, for example, when I will be studying with my students in the course, so whatever we'll be studying, we'll be making our own list of differentials. So the moment the student hears chest pain, all of a sudden they should have the breakdown of that chest pain differential diagnosis right away. They should not think over that. So those lists, everything has to be memorized. It will not come from Toronto notes. So Master the NAC is a good book when it comes to questions, but you still have to summarize a lot, because you have to fit in everything in those 8 minutes. And in those 8 minutes, it's you and the patient, both are talking. So even those 8 minutes are not your own. You can say you'll have just 6 minutes for your material. I hope I have answered your question. If there's any confusion, you can ask again.
No, that was perfect. Thank you so much.
Okay. So yeah, we have Sajia. Yeah, yes, please go ahead,
Yeah.
Sajia.
Hi, doctor.
Hello.
I have a question about dermatology. Is there any station from derma, and how would that be presented?
Derma is not very high yield. Okay, you might get derma in the form of, for example, the patient comes to you with stomachache, okay, or a belly pain, and when you see at the list of their vitals, they're all normal. And when you do the physical examination, it is all normal. And then you ask about any history of, any previous history with herpes and all that. So they might tell you that. But derma, or it can come, with some stations mixed up, for example, rheumatology and derma mixed together. But there is no specific separate derma station that I have ever heard of or even read in the books. Yeah, if you get something and it's your bad luck on that day, that is different. But to be honest, I have never, in like past 3 years, I've never heard any derma stations, and not before that. Yeah.
As you you have spoken of rashes, so will there be any rashes on those patient, as it's totally scripted?
No, usually it's not like that. Yeah, whatever my experience is, that they don't put like makeup and all that that much. Yeah, so the cases are pretty much the cases, because they are not testing your diagnostic skills. Okay, NAC OSCE is not for diagnostic skills. The NAC OSCE is for your communication skills. They are testing you on a different level. They are testing you that how good are you when it comes to a doctor-patient interaction. They're not interested in the exact diagnosis. I'll give you an example that I had a station. It was only a history station, and it was a psychiatry station. The task was just to take the history of the patient. That's it. Complete 11 minutes. There was no post-encounter, nothing. Because psychiatric history is very long history. You have to rule out all the psychiatric conditions. So I went in, I took the history, I did everything, and the time was up, and I kept quiet for a minute, and then I thought, am I missing something or what, And then I don't know why I just blurted out to the patient that I think you have schizophrenia. And in my mind, I knew that it was a delusional disorder, but it was not a proper, maybe a mind and tongue coordination. And the moment I said that, the patient popped her eyes out and she said, "What?" And I popped my eyes out and I was about to say, "I'm sorry," and then the bell rang. So, I left the room in a very confused and that state. So it's not about they're not checking your diagnostic skills. So rashes and all those matter when they're checking your diagnostic skills. That are you able to identify this rash or not?
Oh, thank you. Thank you very much.
Yeah. Okay, so is there anything else that anyone, are there any questions in the chat box? Let me have a look at the chat box. I think they have pretty much answered everything. Someone was asking me that about the cost of the, about the cost of the session. So it is $400 for 2 months per student. It's here. So the classes will be starting from January 6th all the way to February 26th. It will be twice a week. I will be preferring early mornings like 9:30 to 12:30 Mountain Time. That is the Calgary time. And fee is $400 Canadian. And I have a plan to cover almost 160 cases. And I will have just 12 students in each batch, not more than that, because I want all the students to get a chance to participate and get evaluated. Yes, Hajar, you have a question, please?
Yeah, how many times you are planning to do this kind of course per year?
Per year, I think it's every time it's with the NAC session. So now this session is in May. The
Okay.
next session would be in September. Yeah, so before it depends at how this session goes, how my students will do in this May. If I feel that I'm a good teacher and I can go ahead, then definitely, yeah, I will do that.
Okay. So
Yeah.
with each exam date, you are going to do one course or two?
It depends on the number of students. If I get more than 12 students, then I'll divide that into 2
Okay.
batches. Yeah, it depends on how
Okay.
many students I get.
Thank you.
Yeah. Okay, and is there any other thing that let me have a look at the chat. So
I have a question, doctor. It's about the
yes, please go ahead.
relaxation. So, like a pediatric case is like there will be no pediatric patients.
Yeah,
The parents come with the concern.
yeah. Yes, on pediatric stations, there are no kids over there. The parents are there with the concern, and the parents are there. You have to talk to the parents, and then the history is different. Yeah, and when it comes to teens, can be there. Teenagers like 13-year-old, 14-year-old, 19-year-old, teens can be there, but peds, no, only the parents are there.
Okay, teens will be there. Okay.
Yeah, yeah. I had a 17-year-old. Yeah. So yeah, teens can be there. Okay, so I think we have I've done all the questions, and I think Nandini is Nandini still here or has she left?
I am still here.
You're still here. Okay. So,
Yes.
yeah, if you have, just before I wrap up everything, Nandini, I'll show you the slides once again. Nandini is my very good friend from QE1. So anything for friends. So Nandini, I'll go back to the beginning. I'll show you the slides. But for rest of you, for the email, I have posted my Telegram channel link already. And the email address, I'll just post it in the chat group. It's medicinebyheart@gmail.com. You can ask me any queries if you have, or if you want to register for the course. I'll be looking forward for a positive response. Thank you very much for your time. And I think that is pretty much from it, unless anyone wants to have a review of the slides again. So Nandini, I'll just quickly